Dear urologists, welcome to Pure Urology. As you all know, Pure Urology is a surgical technique-based Facebook forum where for exclusive urologists, we are giving insights in the surgical techniques and myself also learning from various faculty across the world. So today topic is PCNL. As you all know, PCNL is the bread and butter surgery for last 2-3 decades. Even now, I feel that one should know PCNL very well to do surgical urology practice. PCNL is usually invasive procedure when compared to ESWL and RIRS. When you do invasive procedure, you need technical skill as well as you need experience. Generally, it is done under general anesthesia, spinal anesthesia, because in prone PCNL, patient will be on the back, will be facing to the surgeon, whereas in supine PCNL, front will be facing. When I kept today's topic in the Facebook forum, in WhatsApp groups, lot of people argued, is it correct to do under local anesthesia? It is not correct. Everybody is saying, can you accept on your relative like that? But science has always dimensions. When I searched the literature, hundreds of patients underwent PCNL under local for various situations. Like emergency situations, we all do PCN under local. Then they say, why not PCNL? Like that, severe breathlessness, not able to give anesthesia. Sometimes people say spinal is safe, not safe. GA is more safe in the present era. So in such situations, even I have not done any local PCNL. I have my own hospital. I take luxury of general anesthesia. Happily, I will do slowly. 2,000-3,000 Indian rupees will be extra. I don't mind. One of my colleagues is saying, if you do PCNL under local, surgery and surgical technique is same, but patient will suffer. So is it correct? Let us see in a different angle what conditions today surgeon Dr. Aravinthan has done under local anesthesia. We will see. Before handovering the program, I will introduce Dr. Aravinthan. He is talking today about awake PCNL in resource limited setting. Dr. Aravinthan is from Sri Lanka. In Sri Lanka, what I have seen, it is FRCS and London style of training is more. They document, they write papers, they are scientific. Even their dresses, they wear like European style. They are very formal. I have been to 2 live workshops in Sri Lanka. He is also FRCS Glasgow and diploma in urology. Consultant urologist from Sri Lanka with over 15 years of clinical experience, MBBS, MD surgery, FRCS Glasgow, diploma in urology. He has performed approximately 2,000 PCNL procedures with proficiency in both supine and prone techniques. He has undergone fellowship training in King's College, London. He is recipient of the Young Urologist Award by the Urology Association of Asia. He has contributed to multiple publications in international and peer-reviewed journals. His academic interests include surgical education, training, and innovation in stone disease management. He is a member of SLOS, SLCS, UAA, and the Royal College of Surgeons. When I was searching the literature before I have given the topic, his name article is also there. I am happy with this introduction. Thank you, Dr. Aravinthan, for accepting the invitation. And now it is your turn to convince in which cases you have done such procedure. Thank you.
Thank you, sir. Thank you. First of all, I want to thank you to give the opportunity to talk on this platform. So thank you, sir. Can I get the PowerPoints?
Yeah, your PowerPoint is with you or with us?
I think I
you can share the screen. You can share the screen now.
Right.
In the bottom line, yeah, it is open.
Yeah. Right, thank you.
Yeah.
So when I started this awake PCNL, the awake PCNL, honest with you all, I'm not going to talk anything new because here the PCNLs, urologist, maybe there are a lot of urologists may be doing PCNLs. So it's nothing new in awake PCNLs because as the Dr. Chandra Mohan sir said, we do a lot of PCNs. We do a lot of percutaneous nephrostomy. So the same principles and same techniques I adapted, and I'll change a little bit. I changed a little bit because a little bit to accommodate the PCNL surgeries. So awake PCNL, when we come to the awake PCNL, we all know this is a long story, long history, maybe around 20, 30 years. Initially, we started with, how to say, it's a large caliber PCNLs, large standard PCNLs. We dilated up to 25, 28, like that. With the time, the techniques evolved. We came to mini PCNL, micro PCNL, ultra mini. There are so many PCNLs. So this awake PCNL also one of that. We just modify the techniques and standards and some criteria just to accommodate the group of patients, few population of patients, not for all the patients. Because in your current practice, you would have seen some population of patient. You may have a pool of the patients for PCNL because I have around 300, 400 PCNLs in my waiting. So out of this waiting population, the few population, they are discriminated or they are neglected. How to say that? They are not given a proper options because of their morbidity, because of their diseases, heart disease, or COPD disease, or some poor mobilities like that. So because of the comorbidities, we just ignore those group of patients. So what we give is long-term stents. So if they come with a obstructed, infected system, we give a stent, maybe under local anesthesia or some sort of PCN under local anesthesia again. And we leave that population to the society just to be with a PCN or a long-running stents or long-term stents. So I target those groups. And the awake PCNL is targeting those population only. Because that's what I'm telling again, this is not a new technique. We are just redefining or restructuring our stone surgical skills or stone surgical principles. I'm not violating any principles. I just follow all the principles, one for a PCN and one for a PCNL. So I just combine both and I'm doing awake PCNL for those group of population.
Yes.
So what I'm going to talk today, so it's very clear why I choose or why people wanted to do local anesthetic PCNL. It's again, I'm telling it's not a new technique. There are a lot of papers, not a lot, maybe enough papers in the literatures. There are Chinese papers. I'm not sure about the Indian papers. There are papers in the literatures. They have done hundreds or thousands of PCNLs under local anesthesia with modified PCNL techniques. So I'll talk on that. And how to select the patients. And important slide is the local anesthetic techniques, how I'm going to give it, because that is important. But if you don't give a local anesthesia properly, the patient will run middle of the surgery, or patient may trouble you the middle of the surgery. So that slide need to be need to be given properly. Then I'll go for a surgical steps. It's nothing new, man. Nothing new. It's a standard steps, but I modified a little bit. I modified or I changed according to the patient comfort, just to make the patient comfort and myself comfort also. And I will give my outcomes. And I have seen some complications. It's nothing to hide here. So I have seen some complication. I will talk on that. And I will give a unedited video to you all just to see, just to enjoy how to do the local anesthetic PCNL. So again, I'm telling the why awake PCNL. It's just a shift. It's nothing new. I'm I'm not introducing a new techniques or a new technology or a new things, new principles to the stone surgery. It's just a shift. And you all know the general anesthesia. It's a risky. There are risks associated with general anesthesia. And there's a group of patients. That's what I said. It's a high risk cardiac, pulmonary, or elderly patients. We have to have some sort of at least some options for them. We can't just put them into the waiting time. The society saying you should be on a long-term stents or you should be on long-term PCNs. So if that is the permanent option, then that's also fine. They can be on stents for a long time. But in your practice, you would have seen those are the patients. Time to time, they come with a hematuria or sterile pyuria or recurrent urosepsis, recurrent infection, and they trouble you. So we target that patients. And local anesthetic PCNLs, the fast post-operative recovery and mobilizations. Honest with you all, we discharge in the same day or within 24 to 48 hours because Sri Lanka, we don't have fast discharge patterns because the transport facilities and the feedback. If there's something happening at home, there's no way to come back to the hospital. So usually we keep for 24 to 48 hours because of that reason. But patient woke from the bed after the procedure. The patient usually walk from the operating table to the recovery. And the cost, of course, we are developing countries. We are just we have to think about the anesthesia-related cost. And the important thing is the real-time patient feedback. Some patients, if you talk to the patient, if you reassure them that there won't be any pain or there may be a little bit pain, but you can see your procedure, you can enjoy your procedure. If you convince them, then some group of patients, they like to have it under local anesthesia. And your anesthetic colleagues definitely will be happy because they have full control over the airway. So these are basic slides. Why? So what is PCNL? It's a simple thing. It's a gold standard for a large or a complex renal calculate. And it's a high stone-free rates, you know. So the awake PCNL is only to the high-risk patients and definitely need a high-skilled surgeon to perform this. Right. Now, again, I'm telling you have a population of patients, population of PCNL patients. You have a lot of patients maybe in the waiting time. There are so many patients meeting you on your clinical practice. But this awake PCNL is not for all the patients. If your anesthetic is happy, if your anesthetic is happy to give a general anesthesia, or if your anesthetic is happy to give a spinal anesthesia, and patient also not willing to have a GA, willing to have a spinal, please leave them. Don't touch them. Don't bring them saying that, no, I will do under local anesthesia. This is a good one, you will blah, blah things. It's not. Patient won't cooperate with you.
Great.
It's difficult for you. You can't sleep at the end of the day also. So let them to have a GA PCNL or a spinal PCNL, whatever the PCNL, they can have it. There's a population of group. There's a population where there's a GA also risk and the spinal anesthesia also anesthetic is not willing to give. So you target those groups. They will cooperate with you. You can have your surgery under local anesthesia with 100% success. Trust me. So when to choose awake PCNL? The patient at high risk for, that's what I'm telling again, the significant COPD or restrictive lung disease, a patient with a cardiac comorbidities, co-ejection fraction, arrhythmias. Obesity, actually, I don't prefer that because obesity difficult to give the anesthesia and you just leave that. And sometimes the anesthetists say that the airway is difficult airway, difficult. So that patient also you can just touch and see. And some patients prefer, if you talk to them, if you convince them, they prefer to have the local anesthesia instead of the general anesthesia. So those type of patients also you can take to the target group. So when to avoid, it's important slide because you should know when to avoid. No, don't bring all the patients and put in the table and run into trouble. So if the patient is anxiety, when you take, then Dr. Chandramohan sir said, there are so many comments on the Facebook worrying about their anxiety, the urologist anxiety. So think about the patients. So their anxiety, someone say, no, I'm going to pass these cameras through your loin under local anesthesia or when you awake. So you talk to the patient. If they're anxious, if they don't like it, just leave them. No problem. We don't want them. And some patients, even they like it, but they don't like to tolerate the awake procedures. You would have seen enough patients, for example, the circumcision we do under local anesthesia, but some group of patients, they ask for a general anesthesia or some sort of regional anesthesia because they are scared. They would have gone through the internet and the chat GPTs and the YouTube videos. They are scared. So that group also not matching here, that leave them also. And the stone findings, if the patient having stack phone stones or multiple stones in the different calyces, if you think this patient need a multiple track or 2-3 tracks, and it take a lot of time, maybe some PCNLs we know it take around 3 to 4 hours time. So those patients also, the stone factor is also very important. You have to carefully select the patient. So good, the ideal candidate is the 2 centimeter or a 1.52 centimeter or 2.5 centimeter PUJ stones with the hydronephrotic patients with the comorbidities. We see a lot of patients. We have a lot of patients in the waiting time. Time to time they come with the urosepsis. So we can target those patients rather than touching the patients which I have listed up to now. So cases requiring multiple access tracts, then significant spinal deformity, because if the patient having spinal deformities, you can't put it on the table, because I did all my PCNLs in the supine position. Because the prone and local anesthesia, I haven't done it, but I don't know it's working. And uncooperative or a non-communicable. If you can't talk to the patient, if you can't convince the patient, if you can't build a rapport with the patient, don't touch them, because if they trouble you during the operation, they trouble you. So you ignore all these things. Get a good patient or adequate patient, good patient, good selection of patients, good patient with the dilated system and reasonable size stones. Definitely you will be success. So this is the important slide before getting to the awake PCNLs. The counseling, you have to counsel the patients. You can't just, like your GA or a spinal anesthesia, you can't just take the patient into the bed and do it just to say, I'm going to do a PCNL on you. Like it's not like that. So you have to counsel the patient. You have to spend a lot of time with the patient. You have to explain the procedures. This is going to happen. You will be awake. You will feel everything. A lot of sensation because we touch you, we just spread your legs, we clean without, you feel that, because how you do flexible cystoscopy, you do like this. So nothing new to tell, but better to tell. And the puncturing, they may feel it, but I don't believe they get pain. You can see my videos. And an important thing is when you send the irrigation fluids in the kidney, it's a warm or a cold sometimes. So they feel that something going inside. So you reassure them, nothing. You may feel that, but nothing will happen. Don't worry. So you just talk to them, listen their expectations, and tell them this the cooperation is very important. Cooperation is very important. Uh, Other thing is the positioning. So tell them that I'm going to put you in the supine position. You just sleep on the bed. It's like you sleep on the bed. I'm not going to turn you here and there. Or it's a lateral modified. There are so many positions. I'll do it in the supine position. You will feel, you can listen, you can ask questions. If you want a break, I can give a break during the surgery. Like that, you reassure the patients. And other things are standards. You get IV access, antibiotics, talk to your anesthetic colleagues. If possible, bring them to the theater and just to support you. Yeah, that's what I'm again telling this, why the local anesthetic PCNL matters. Again, I so avoid the risk of associated with the general anesthesia. I already went this one. Right. Now, up to now, you understand why I wanted to do this. What is the target groups? It's not for all the patients. And especially one point I want to make it, this is not for the beginners. This is not for the beginners. If someone's starting the PCNL, you can't start with the awake PCNL because you need a lot of skills, a lot of experience, a lot of punctures. You would have seen a lot of complications also, adequate complications also. Otherwise, you won't be able to do it because you know the learning. I also learn sometimes back. So that time we do multiple punctures. You go this way, you go that way. You can't do those things in the local anesthetic PCNLs. You should be able to appreciate the anterior, posterior direction and the depth. Appreciation should be there. You can't just go down and come back again, go above, again go. It's not like that. The patient won't cooperate. Patient won't tolerate. So you should be an experienced surgeon. You would have done at least a couple of reasonable numbers to start with the PCNL. So where you can puncture in a 1 or 2 or maximum 3 attempts, you should be able to enter the calyces. Otherwise, patient won't tolerate. It's a failed PCNL. And positions, if you are practicing supine PCNL, it's good. Because the prone PCNL, if you put the prone patient into the other way around, patient anxious, what is going to happen? Because patient is awake, man. So patient may anxious, patient may ask, what is happening? So they won't cooperate. They won't cooperate. But I haven't done it. But I have seen some literatures. They do awake PCNLs in a prone position also. So supine is the ideal. If something happened, if something goes serious, then the airway is under your hands, under the anesthetist hand. So you can't just do it. You have VI accessible. And I will talk about the renal axis, punctures and dilatation and fragmentation. So I'll come one by one. So first I'll take the position. So this is the standard PCNL. On my right-hand side, you see this is a standard supine PCNL position. But I don't put like this because it's too much of abduction and too much of stretched legs. So what you do, just you keep 2 normal saline or some packs under the one is under. Actually, you can do it in the complete supine position. No need rotation. But if you want to rotate the patient, just keep 2 the saline bags. One is under the rib cage, one is under the iliac crest. You take a little bit around 30-degree rotation to the bed. It's fine. Don't rotate too much. Tell to the patient, I'm going to keep 2 bags under your back. That may give a little bit discomfort for you. It's not painful. You talk to the patient, then they will understand and they will cooperate you. And putting the legs, it's not like that. It's no need to spread like this. You just because you want to put a cystoscope or the flexible cystoscope to get an IV access. The uretary catheter access. So for that, the exposure is enough. So I just put a modified lithotomy position. So it's why supine position, again, the more comfortable for the awake patients, easier airway access, and better communication. You can talk to the patient. If the patient is in supine, you're talking. You just take your hands up. The hands are free for the patient. He can keep it anywhere he wanted. So you can talk to them. You can talk to them what you are doing. I'm puncturing. I'm just passing the catheters. I'm just breaking your stones. You can see on the screen, this is your stone. We are breaking. We are going to put a stent, or we are going to remove it. You can tell. You can communicate with the patient. Patient will be very happy to listen. But only they are anxious because even I something happening on my body under local anesthesia. Yeah, I have to understand that. Right. The renal access is again is an important step. How to get this? Because I have seen some papers. They do under the ultrasound guided. They don't put a uretary catheters, so they just do an ultrasound guided. They puncture. But in our setups, we don't have ultrasound machines in the theaters. But I was thinking how to do that. So how to overcome that step. So I modified that. One thing, we do a flexible cystoscopy under local anesthesia. Just put a flexi in the male patients. You put a flexi, guide wire. CM is just in front of you. You just check it. Pass the 5FR or a 6F. 5FR is fine. 5 French uretary catheter. Tell to the patient something going through your ureter. You will feel it. If you feel pain, let me know. Because you can give sedation, you can give morphine, you can give fentanyl, your anesthetic colleague is there. She's happy to help you. So, and the female patient, it's granted for us. You can do a rigid cystoscopes and a local anesthesia, or even if the patient is more scared or anxious, again, you can put a flexible cystoscope. Same procedures can be repeated. So once you get the access, pass the guide wire, yeah, it's a 0.035 guide wire. It's a tiny guide wire. Pass the uretary catheter and we get the renal access. So you can use the lignocaine gel. Yeah, we are using anyway. The male patient, a little bit difficult, rigid cystoscope. That's usually I do under with a flexible cystoscope and if patient is not tolerating, not cooperating, I ask my anesthetic, I won't
Do
hesitate.
you think
I
that,
ask to give.
sir, sorry to disturb you, do you think that
Yep.
flexible cystoscopy is less painful than rigid ureteroscopy for stent removal or for anything? Are you using flexible cystoscope regularly?
Honest with you, sir, I use rigid cystoscope, not a ureteroscope, a rigid cystoscope. You have a 17, 19. But if
Flexible
patient is young
cystoscope
and
you have
anxious,
used? Flexible cystoscope also you used?
yeah, we have flexible cystoscopes in case if
Okay.
because with the stent removal forceps is it's not little bit expensive and it's time to time it go out of fashion, out of order. So that time we can use the rigid cystoscope, but you have to give a lot of lignocaine gel. The female, of course, no problem, no issues. They tolerate. But male difficult, especially the young people, they won't cooperate, they won't tolerate. We have to wait until we get the flexible cystoscope at least and do it. So that same principles I adapt here to put a guide wire
Okay.
and uretary catheter. So then this is the golden slide. The important slide, you just see how to give a local anesthesia. Now you know the anatomy, the skin, subcuts, muscles layer is there. You have to go up to the renal capsule. You have to go up to the renal capsule. Otherwise, patient won't tolerate. If you give just under the muscles and start it, patient struggle, patient trouble you. So take a needle. So lignocaine, so the local agents, I use the two. I combine the lignocaine and the marcaine. So the lignocaine is, you all know, it's a short acting, or sorry, the quick acting and short acting, and the marcaine is the bupivacaine is a long acting. So you can mix it. You can mix it, no problem. According to the body weight, you can go up to 20, 30 ml, the mixture, the minimum one. So you can go 30, 40 mLs of the combination. So you make it in a one syringe. So use the IV cannula because you want a little bit the longest one because you have to go from the skin to the renal capsule. It's the longest one. So use the IV cannulas. It's a small one because you can't go for a very tiny one because it won't go through the muscles layer. It may bend. These are the practical issues. I just tried the small one. It's bent. So maybe around 18, 20 is fine. Sometimes I use 16 also. So there are two types of giving the local anesthetic. You all know this. You can just infiltrate the local anesthesia in advance. So you go to the skin, give something to the skin, a little bit around 5 ml to the skin and the subcuts. Then when you advance the needle towards the calyces, you infiltrate. So I practice other way around because here the PCNL, we should know which direction we are going to give it. So what I do is I just keep the needle on the patient's body. Under CM, I identify the AP direction, which direction I am going to give it. But the depth, of course, I don't know. It comes with your experience. That's what I'm telling you. You need a lot of experience to do a local anesthetic PCNL. So depth, it's appreciated or you learn. So in that track, you just go up to you hit the pelvis, sorry, the renal calyces. Then from that point, you give around 5 to 10 to the renal capsule. And the command, when you withdraw it, you know where the muscles you hit it around again 5 to 10 ml to the muscles. And another things you can infiltrate on the subcut and the skin. So nearly about 20 to 30 ml is enough to infiltrate or to anesthetize the PCNL tract. So that's what I'm saying. I said that there are literatures, the papers say that people do ultrasound guided local anesthetic infiltration. If it is available, you can practice that. But I did all my cases under fluoroscopic guidance, local infiltration, needle puncture, like that. Then come to the PCNL puncture. It's a standard one, standard how you all do the standard PCNLs, the 18 French puncture needle we needed. It's a two-part needle, two-core needle, just give it. So after giving anesthesia, you leave it for 1 or 2 minutes, 3 minutes, just give some time and tell to the patient, this is, I'm going to puncture you. You may feel it. Definitely you will feel it. Or you may get some turkey feeling, but don't move it because again, the problem is under local anesthesia is the respiration. We have no control over the respiration. So kidney will move here and there. So you have to puncture when the kidney is moving, So 18 French needle. So try to do it as a single entry. It's difficult, but with your experience, you can do it. With the depth appreciation and the AP appreciation, it's a triangulation technique. Just go. It's a freehand technique. Just go and puncture it. You will. So need experienced hand. So mostly in one plane is enough. If you are enough experience, if you know the depth of appreciation, you know the depth where you are going. So one shot, it's enough. In the difficult cases, don't compromise yourself. Just turn the C-arm or a 5 or 10 degree lateral and appreciate your depth and adjust the needle accordingly. Do it. You will. Then pass the guide wire. So this is a learning slide. If you want, you can copy it. So the key elements are the 18 gauge puncture needle, almost single entry or 2 or 3 entries, should be experienced hand, skilled operator, essential, just to get the depth and the angle judgment. Right. So this is another important step. So second important step is a tract dilation, where the patient try to jump from the bed. You all think, but it won't. Don't worry. Because what we do in the PCN, percutaneous nephrostomy, you go up to 10 French dilatation, put a nephrostomy tubes, patient never jump. Even the radiologists are doing that. So why are urologists, we can't go. So we have to go up to, some papers say it's around 20 French they have dilated. 20 FR they have dilated. But I do here the 16.5 because my nephroscope sheet is a 16.5. So I go up to 16.5. But honestly, you can check in the literatures, they go up to 20 French dilatation under local anesthesia. So this point is, so it's mostly a single step, but people say it's a balloon dilatation is less painful. I haven't done that. So my dilatation is a single step dilator. Go with a fascial dilator first. Again, you pass the PCNL single step dilator, then go with the sheath. So if the patient
But
say,
when you are
oh,
doing,
if patient,
sorry, but when you are doing
yeah,
single step dilatation, won't you apply more force on the rectus sheath so that patient gets pain? For example, if you do slowly one by one, one by one in local anesthesia, I'm not just getting, I am a crazy step by step person for beginning last 20 years. Somehow I have not changed. Whenever I do forcibly rectus sheath, if it is strong, obese patients, okay. But rectus sheath young male, I feel I have to use a lot of resistance. But many PCNL surgeons do single step. So what is your take?
yeah, here I give a 10 French dilatation first. First is a guide wire, then 10
Yeah,
FR or 8 FR, the fascial dilator. After that, it's a 14
yeah.
FR. It's around 1 or 2 millimeter more. And if patients say pain or it's a little bit discomfort or if patients struggle, I don't hesitate. Ask your anesthetic colleague to give a morphine or a fentanyl or sedate her. No problem. They can have a good sleep. So this is the point you need anesthetic help if they are available. Otherwise, you give a morphine or some painkillers, pethidine, like that. You can sedate her. So they will cooperate. No issues. So once you get into the tract, the renal, the pelvis, when you get into the axis, the rest of the thing is similar to your standard PCNL. So you have to fragment it. You have a laser. So you can use whether it is fragmentation mode or the dusting mode. It's a simple. So usually I do a fragmentation because it's a little bit quick. And because we are doing under local anesthesia, time is the matter. So we do fragment it and we drain it through the PCNL, the mini PCNL sheet. So here the the essential principles or important steps are the continuous reassurance. The people say it's a local, it's not a local, it's a vocal. You have to talk to the patient. You have to talk to the patient. Again, you have to talk to the patient. It's very important. So continuous reassurance. I'm just doing puncturing. I'm just dilating. I'm almost done, almost finished. Your stone is completely cleared. Please hope help. You like that, you have to reassure, continue you. And you ask about the pain. Time to time you ask, you have a pain, you're okay. Dear my dear, you're okay. You ask from them. If they say pain, reassure them. You can't get pain like this. If they struggle, then you top up your local anesthesia or just go for a sedation with the morphine or a pethidine. So you can adjust the sedation. So if they say that there's a Chandra Mohan said the dilatation, dilate through the rectus muscles may be painful. Yeah, it's a little bit. So you stop. Go for a slow dilatation. You slowly tune it, slowly turn it. So go slowly, gently. So only one step is the problem, is the dilatation. So you do it gently, take time, talk to the patient, reassure the patient. If they tell pain, please give, don't hesitate, please give morphine or additional pain relief. So after the surgery, you think about whether it's a tubeless or a tube PCNLs. Most of the time, we select the small stones, 2 centimeter, 1.5 centimeter, like the stones. So it's a tubeless PCNL is fine. So if you want to put a stent, again, the same steps. You just put a guide wire. You already have a guide wire. So just you pass, you put a guide wire because you remove the guide wire. You put a guide wire again and pass the stents. Here I a little bit modify these techniques because the stent removal or forgotten stents are killer in Sri Lanka because we do a PCNL, we put a stents, they think they disappear from the system. After 2-3 years, they come and tell, no, doctor, you have removed my stones. But they didn't know about the stents and they come with the encrusted stents. So it's one real problem, real headache, real mess in the developing countries. I think the India also, it's a common problem. So what I do
everywhere, even in America also, it's a problem to my knowledge, because sometimes communication on the paper will be there, but it will not be into the brain of the patient or the attendant. If somebody else is loosely communicated, they will forget.
Yeah. Other thing, the Sri Lanka, the developing countries, they have their own problems. One issue is the stone. They have the economic problem. They have family issues, lot of issues. With that, they forget it. With that, they forget it. And they think that once the stone is removed, it's removed. After that, no need follow-up, nothing. Because they don't get any pain. They don't get any symptoms. So what I do is here, if I think the stent is needed after the PCNL surgery. So it's a tricky time it's a 48 to 72 hours or a 24 to 48 hours. If the stones remain, it's going to be a long-term stent. I can't do like that. But if I give a stent for some PJ, the inflammation or a bleeding clot like that, so I give a temporary stent. That's called the stent on string. So I put a string on one end of the stent and just I put it antegrately and keep the stent out of the PCNL, the incision. So after 48 hours, you can just pull it above. So no need flexible cystoscopy. So before the discharge, you can remove the stents. Or you can ask the patient to, even you discharge, ask the patient to pull it above, pull it that thread at home, or just go to the closest dispensary and pull it out. Nothing will happen. Don't worry. So it's 48 to 70. If you leave it for long, yeah, what you are thinking now. what is pressing on your mind is it's epithelialization, and the tracheotomy close it. So that is one modification I do. So the clinical outcomes of my surgery, because it's a very straightforward cases, I have done it. So stone-free rates are almost to the standard. It's around 100%, I can tell. So local anesthesia complications, the pain, the patient tell pains time to time. So just I manage with the top-ups and sedations. And patient satisfaction is high, even though at the beginning, before starting, they may a little bit anxious or a little bit reluctant, but after the operation, they really appreciate and they go home on the same day or the next day. It's a very, very short hospital stay. So the complications, the pain during dilatation, that there's a point that Chandra Mohan made it, pain during dilatation. It's the most common discomfort point. So do manage with the additional analgesics or additional sedatives. So bleeding is very little bit rare because I told you, you select the case properly. You don't go for a multi-track PCNLs or a very complicated PCNLs under local anesthesia. You go for the straightforward or a very simple PCNL, the like around PUJ stones, maybe around 2 centimeter, 1 centimeter, or 3 centimeter PUJ stones with a dilated kidneys. So most of the time, no bleeding. It's a straightforward cases. Infection is common because after the operation, because these all are already infected kidneys. That's what I said. These patients on long-term stents, multiple attempts of multiple visits with the urosepsis, sterile pyuria, hemature. So it's a long-term stent. It's a chronic pyelonephritic kidney. So infection after the operation, the infection is a little bit common. So we give the antibiotics, we give stents, we manage accordingly. So visceral injuries I haven't seen, it's very rare, but I have even the ligages is not mentioning the visceral injuries when someone do local anesthetic PCNL. So that's the final slide. So additional infiltration, if you want to target top-ups at puncture site, dilation points, you give top-ups. Don't hesitate or don't reluctant to give additional anesthesia. And if the patient not cooperating, patient is telling pain, again, you stop it at that point. You talk to the patient, reassure them, again, you restart it. Short breaks, reduce the anxiety and muscles tension because muscle is under tension. It's local anesthesia. There is basically no anesthesia. So muscles is rigid. So difficult to stretch it. And you can give low dose of opioids. I already said that. And if you want, you can give NSAIDs, additional painkillers, pain reserves like that. Right. So up to now, I talk about the theory behind this, now the principles behind this local anesthetic PCNL. So I can move to the case example. I have done around the reasonable numbers. I published the papers also. So I take a very straightforward cases here because this is the discussion forum. I don't like to bring a very complicated case and struggle. So this is a 60-year-old lady come with a severe COPD, 1.5 centimeter or 2 centimeter renal pelvic stones. So this lady time to time. So initially we gave a local anesthetic stenting when she came with a urosepsis. We just did a local anesthetic stents and give antibiotics, so he recovered and went. So this patient was discussed, the options ESWL, the renal scopes, so all the options discussed, but problem the patient is having a lot of comorbidities, cardiac issues, ejection fraction 30 to 40. So they are not fit for general anesthesia. The anesthetic team totally refused that. But the patient come with a recurrent urosepsis, frequent stent blocks. You all have seen a lot of patients like this, or enough patients like this, and poor quality of life. So I thought of doing the mini PCNL under the local anesthesia. So I took around 30 minutes, 20 to 30 minutes. The single or 2 days, I said it's a 24 to 48 hours hospital stay. Complete stone cleared, no complications. I discharged this patient with a stent on string. I told you because these kidneys are infected kidneys or a septic kidneys. It's a pyelonephritic kidneys. So you can't just leave them without stents. They come with the infection again. They gain the problem. So just give a stent and discharge. Again, after 48 hours, they can just take it out. So these are the x-rays of the patient. Even I couldn't put out proper stents because it was done at a local anesthesia. So it's coiled, but it served the purpose because it has gone above the stones. These are CT films. You can see around 1.5 centimeter. So I'll play the CT here. So just line it. So now yeah, it's on the right side. Yeah.
It is stented.
So you see the kidney. It's a pyelonephritic, very thickened kidney because of the recurrent infection. But it's feasible. It's a dilated calyces are there. So I choose this patient for the awake PCNL or a PCNL under local anesthesia. Right. Right. So this is the unedited video. I don't like to edit anything. Just type because the recording quality may not be good because I have my camera head is not that much good. I apologize that, but you can see the surgical steps here. Right. So I'll run it. So this is the so this is the position I was talking about. You all. So it's almost flat. This patient is almost flat on the bed. I didn't keep the normal saline bottles there because this is a little bit discomfort or a patient may think, but it's happening on the back. So I just put a flat position. You see. So the legs I kept, I will show you. This is a little bit dark. Yeah, you can see the legs. I didn't abduct like the typical or a modified Galdavia position. It's just the one leg is totally straight.
I also, sorry to interrupt, I also say that for all the juniors, if you are not planning anything from below, from the urethra, this is the ideal position. If you wanted to do only PCNL job, you have already placed ureteric catheter, you already everything ready, keep the leg in straight position has a lot of advantage in supine PCNL. This is a very important point in this picture. Thank you, sir. Proceed.
Okay. So I didn't abduct too much because this is a local. So we talked to the patient. We explained to them what I'm doing downstairs. So now it's clean and draped. So it's clean and draped. So I'm doing under local cystoscopy, local anesthetic cystoscopes. Sorry, give me a minute. Sorry for the trouble. Yeah, right.
So, how many minutes video this is?
This is around 10 minutes.
Okay. Don't pause.
This is
Let it
unedited.
continue. Don't pause. Let it continue.
Right. Okay, that's good.
If you pause, there is a problem. Keep talking fast according to the video.
Right. So this patient, yes, I'm doing a
Undergoing
local anesthesia.
local
Yeah,
anesthesia,
it's
you
a
are
ureteric
passing the
catheter
ureteric
placement.
catheter. Okay.
Yeah, because as the ureter is dilated, you can see the UO, that the pus is coming. You see that pus is coming. Yeah, right. So the ureteric catheter is passed. Patient is silent. I can put a voice if you really wanted, the theater voice. There is no noise. So this is I want to force it and tell you. So this is the PCNL track, the mini PCNL setup. So I have a 16 FR, the mini PCNL set. So Then the local anesthesia, just we are mixing the, I told you the 10 ml, 10 ml, 10 ml, 10 ml. The local anesthesia, it's one syringe. You take it in a one syringe. It's a IV cannula, IV needle. I can't say it's a small one because I can't puncture it through the muscles. So it's around 20 or 18 or 20 in one syringe, right? First, you have to locate it. You have to locate it where you are, which direction you are going to give the, which direction you are going to infiltrate it. So you see that. Yeah. So this is the X-ray. So I'm taking the X-ray now.
So you will
So you
keep in
see
the
this is
direction
the
of,
important view. Yeah.
yeah,
Just start
yeah, yeah.
keeping the needle, keeping the needle on the body of the patient just to get the AP direction. Which direction I'm going to make the track. So this is the typical one. So once you get this idea, you infiltrate it. You go in and infiltrate it. Sorry. Yeah. So now I'm just, yeah, now I give a, so this is again a little bit modification. You can give a separate, the local anesthesia around the small needle, you use it and give a 5 ml anesthesia around the skin. But I just use both because I'm now doing the more cases like that. So I'm going with a needle, local anesthetic needle is advancing. So it's difficult because the patient is breathing, patient is feeling, so it's breathing. So with the breath, but I have to catch that direction. I have to catch the direction. Otherwise, I won't infiltrate anything. So I'm just almost close to the capsule. I'm almost close to the capsule. So I infiltrate that. Now I'm just checking the pain, checking the pain. So this is the puncture. It's a puncture needle. I'm just touching and asking from the patient whether she's in pain or not. So I make a small cut there.
That puncture area local is very important.
Yeah, that is very
I
important.
think.
So I'm just puncturing now. Even I say I am an experienced surgeon, but I struggle a little bit because the patient it's breathing and it's a video wave, something going on. So it's not a puncture. It's just above, superficial to the kidney. I appreciate that. So I just withdraw. So I keep the tract in the same direction. It's also not punctured. It's not punctured. It's not punctured. Yeah, it's you see the turk in the kidney. When you once you enter into the calycis, you see the turk. The kidney moves a little bit away from you. Then you know you are entering into the calycis. You are going into the calycis. You are going into the calycis. Still, I'm not happy. So just I withdraw that because the puncture is very important. If you miss the puncture, you miss the case.
Yeah.
Right. Now you see that. Yeah, you see the turk there. Right. So it's a dilated system. It's a baby puncture. Right. No. Now I punctured. I get in. I saw blue. So the blue is coming now. So I'm very happy now. So this is the pulse, blood pressure is almost the same from the pre-op. This intraoperative monitors. We monitor the pulse rate. If patient is on pain, the pulse rate should go up, BP should go up. So it's same. Then we pass the guide wire. It's a 8 or a 10 FR dilatation. The fascial dilators is going on. And yeah, patient still just sleeping, patient cooperating, no pain at all, no complaint.
Do you give sedatives? Do you give sedatives?
This point, sir, I was giving. Usually I give at this point if the patient says something. Otherwise, I won't give. Most of the time, I give during the dilatation because you said that going through the muscles is tricky. So this is a one-step dilator. Straight away it went in. So I go up to the pelvis because you see the stone somewhere there. Stone is somewhere here. So just we went up to this. Yeah. Right. So now the sheath is inside.
It should be a simple case.
It's a simple case. Yeah, that's what I said. It's a simple case. You select the good cases, then you can sleep in the night. Yeah, we went in.
No, lying down position, it won't happen.
So we went in. So my camera quality is little bit poor. You see the stone there. It's a small stone, just floating.
And pneumatic is less painful or laser?
It's a laser, sir. It's a fragmentation mode. So just I laser it. I break into 2-3 pieces now. This is one of the piece.
In Sri Lanka, what laser is commonly used? TFL or ohmium?
Aluminium lasers. I have a high power laser. Fortunately, my procedure bought that one for me. So I'm just enjoying. So it's nothing. It's nothing. Once you go inside the kidney, it's nothing. Miracle there. You just blast the stone and come out. You can talk to your patient and tell, yeah, the stone is like, we are blasting your stone. Ask her to observe also if she is really, really willing. Right now it's clean. Surgery is clean. Stone is removed. I just forward it. So there are some fragments that can be drained out. That is taken out. So the entire system is now once you go inside, you can just a little bit manipulation. You can't do a lot of manipulation like your standard PCNL because patient get pain because the warm fluids are going into the kidney. And the advantage of urinary catheter, it's decompress the system. It won't let the intrarenal pressure to go up. Now I'm putting the stent. This is the technique I explained to you. Just pass the
Dear viewers, recently one of my friend Arshavardhan has done RIRS in sick patient under local anesthesia. See, apart from criticism that local should not be done, there are few insights we have to look into. Sometimes in periphery, when the juniors are doing URSL under local, anesthesia spinal will not work. So you should know what causes the patient pain. Can we do it or not? Can we do it or not? Number 2, transurethral incision of prostate versus rhizome heightened and the Urolift. They are saying that it is done under local anesthesia. Why they are promoting that much? Young patient and old patients who cannot tolerate GA. Are there any patients really who cannot tolerate GA is low ejection fraction less than 20%? So these patients, if they are on catheter, if they are sure that prostate is a culprit, can you give laser incision without pain? I feel it can be given. I have done en-bloc resection of bladder tumor once without anesthesia. So which areas of the genitourinary tract is painful? We have to read. Hello, sir. I was
sorry, sir.
entertaining. I was
The connection
talking a
is
little
good.
bit. Yeah,
Thank
okay.
you.
You share the screen. We
Yeah,
will
give me a
continue
minute.
from there.
You see me now?
Yeah. Very much.
Right. So I'm almost
Yeah,
done.
we are making you
Just
we are making you co-host. It is co-host now. You can start from the same place. Don't fast forward or don't pause. Then it finishes.
Right. Yeah, this slide. So I stopped here. So the calyces are clear. There are some fragments there. Right?
Yeah. Do you
Yeah,
think
right.
that
Thank
any
you.
patient gets a vagal type of picture, bradycardia, not vasovagal, vagal stimulus like that? No,
No, I didn't face those type of
such problem.
situation.
How many cases? Can you open the screen, your video?
It's not visible.
No, video is not visible. You have to share again.
Share again. Give me a minute. Now? You see now?
Yeah.
Right. So this is the important step.
You pass the
Yeah. Now the
stent
stone is.
over the guide. You pass the stent over the guide wire.
Yeah, I pass the stent over the guide wire, and I have a
is-
stent. The stent on string. There's a string on the end, one end.
Yeah.
So what you can do it, you just pass the stent and leave the stent, the string out of the PCNL incision. You make around 0.5 centimeter incision,
If
stub
you go
incision.
from lower calyx to upper calyx in supine, do you think that the kidney will have torque and pain? Any idea or no?
Actually, this case, I went from the pelvis to the upper calyces. That's what I'm telling.
Yeah, that's what
So
I'm
once
seeing.
you enter
Did
into
the
the
patient
kidney, you can
did the
just
patient complain? Did the patient cry
no
or
complaint,
anything? No, no
nothing.
complaints.
Yeah,
So you
because I
can
have the
move from
original
one
voice
calyx
of
to
this
other.
surgery.
Yeah, okay.
So once you
So you put
enter
the
into
guide
the
wire
kidney,
completely across and then put the stent.
yeah. So
Okay.
you can watch it
Yeah, I'm able to see.
because the proximal end is the tie to the string. So I keep the string outside the incision. Just I patch it. I plaster on that. So for 8 hours, they put it. Just nothing will happen. Some PCL, some PCL.
Yeah. So that's okay.
So
Hello,
that's
am I audible?
yes, sir.
We will
Yeah,
take the quick. We will take quick questions. 10 questions.
yeah.
Can we close the screen?
Yeah, close the skin.
Yeah. I will close. I will close.
You close it. Yeah.
Okay. So both screens, both faces. I will ask a few questions quickly.
Yeah, I'm here.
Yeah. Number one, honestly
Yes.
tell me which patient is the most benefited with local anesthesia PCNL. Is it poor patient? Is it cardiac risk patient? Is it multiple risks with GA patient? Is it thin patient? Is it a single stone pelvic patient? Which you feel very useful in which patient? Local anesthesia. I will try
So
depending on
local
your suggestion.
anesthesia, that's what I said. Yeah, at the beginning I said the local anesthesia is not for your common populated patients. So you have a group of a collection of patients for PCNL. So out of this, the small fragment of patients benefit from the awake PCNL.
Which fragment I am
So if
asking
you anesthetic
straightforward?
say, if your anesthetic say, no, we can't give GA, we can't give spinal, only the local anesthesia, you just put the stent on under local anesthesia and leave them. So the patient side, if you see the poor cardiac function, or severe COPD patient, or severe the restrictive lung disease, COPD like that. And so those patient side, patient factors. If you take the stone
Okay.
factors, you can't just take all the multicalycial stones or stackphone stones and complicated stones under PCN, under local anesthesia. It's not possible. You can't puncture multi-track PCNs. You can't puncture 3-4 times or 4-5 times to get all the calyces clear. And you can't spend 3-4 hours to clear the stone. So all these factors need to be collected in one patient.
Okay. My
That
second
patient will
question.
be benefited
Understood.
from. Yeah.
Understood. My second question, what is the concentration of local anesthesia? Is it sensoricane or xylocaine or a mixture of xylocaine with some other drug and dilution, anything? How much maximum you can give? Briefly in one line.
Yeah, one line. Yeah, I'll make it two line. So the people the paper says it's some people would have done the pure local anesthetic, pure lignocaine. Some people say it's a pure marcaine or a bupivacaine. So how I did, I'd say it's a mixture. It's a mixture in the sense the lignocaine. It's a short acting, but quick acting. But bupivacaine takes some time, long acting. So you can mix it. You can mix it and you can make a high volume also because you want a volume. You can't just make it 10 ml and infiltrate the entire track around 10-15 centimeter track. So you have to make a good volume, good the reasonable dose. The dose is very important here. So what I do is the body weight, according to the body weight, the maximum, half of the maximum. For example, the lignocaine, the maximum doses with adrenaline mix, 7 milligram or 6-8 milligrams. So you go for a weight around 500 milligram. So it's a half of that, 250, 300 is fine. Like that, bupivacaine or a marcaine also, you can calculate the dose according to that. Then mix it in one syringe, make a good volume. Good volume. And other thing, when you
Now, fourth question.
there's a infiltration, there's a radial effect. The local anesthetic diffuse in the tissues, especially if they are a fat patients, they diffuse. So it's around 2 centimeter wheel or a 2 centimeter, 1.5 to 2 centimeter radius, you get it. You understand my point? When you give, hello? Yeah, when you give a local anesthesia in a one track, you get a 2 centimeter radius of the track. So you can work, you should work within that track. You can't just go out of the track and make a patient discomfort.
Fourth question.
Yeah.
Fourth question.
Yes,
if inguinal hernia, we used to do hydrocele and inguinal hernia in surgical training under the block of the ilioinguinal nerve, 2 centimeters above and lateral to the anterior superior iliac spine. We used to get good result so that local anesthesia amount can be reduced. Do you think that any such block can be given intercostal nerves as well as sympathetic ganglion? Did you ever thought?
Because I didn't think that way, but I also do what you said, the hydroceles, this orchidectomies. You can do it under local anesthesia. It's a pure or the cord block. It's say the cord block. You can give a cord block and do it. Here the multi layers involving. One is the skin, other one is the muscles, and especially the renal capsule. Renal capsule need to be given. The local anesthesia need to be given to the renal capsule adequately. So in that aspect, I am very happy with the local infiltration of the local anesthesia. Yeah.
Okay. Next, which part of the procedure, puncture, initial guide wire passage, which part of the procedure, puncture, guide wire passage, dilatation, last part of the dilation, Ampla sheath passage, or maneuverability with nephroscope, which part is most painful?
It's a dilatation. That's what I've already answered this question. Because the puncture and the fascial dilatation is that much. After that, when you put a 14 French dilator, a single step dilator, you have to stretch the rectus sheath, the rectus muscles, and renal capsule. It's painful and uncomfortable. And if the patient start to scream in pain, if patient is not cooperating, if the patient say sometimes patients say, I want to terminate this procedure, what you are going to do? You send the patient with the PCNL sheet. It's not possible. So that is a difficult step or a very caution, very slowly you have to do it, very gently you have to do it. And in
Correct,
case
correct.
if the patient say, no, doctor, I can't tolerate, it's a little bit pain, it's more pain, if say, then you top up with a sedative like a morphine or a fentanyl or a pethidine, you can give it. And you
Yeah.
wait for some time. You can take a step-by-step approach in this step. You
Correct,
can't
correct,
just,
correct. Agreed.
yeah,
So local anesthesia top up by small, very short acting IV sedation, and then slow step by step and explaining the patient and do it is the other option. Now, which other urological procedure you have done under local anesthesia?
yeah. Most of my cases in urology, and I do under local anesthesia because I have two lists in the hospital. One is the general anesthesia, whatever the anesthetic available. Other list is purely local anesthetic. So we
You
do
are
the
URSL, will you do under local URSL?
URS is not possible because how I feel, because you have to go through the urinary opening. It's like a urinary junction, you have to negotiate, it's not possible. If the bladder
Did
stones,
did you ever tried flexible ureteroscopy with local?
no. Have you?
You have not tried?
No, I haven't said. Have you done or anyone agree?
Okay. I feel I have my friend has done one flexible ureteroscopy post-stented in a sick patient, very small stone, 1 centimeter, powdered and came out. Patient did well. He recorded everything. He was talking to the patient. Over the guide wire, flexible scopy can be done under local, but if you distend with water pelvis, it will be painful, dull,
Painful.
aching, and sharp pain also can occur in the ureter. So not easy. Have you ever
Yeah, that
tried
is.
transurethral resection of prostate under local?
No, I haven't, but I have seen some videos, but I haven't done so. People say. So what I have done is simply say the DJ stents, local DJ stents, insertion,
Uh,
removal,
uh,
some
do you
bladder
do
stones. If the
laparoscopy? Do you do laparoscopy?
I do laparoscopy, but I don't do under local anesthesia.
Some
You're
people
asking
have
that?
done ureteric reimplantation under spinal laparoscopy.
Alright.
Many people
Spinal,
say,
yeah.
in district laparoscopy, appendix, gallbladder, they do under spinal.
Okay.
It is also surprise to me that pneumoperitoneum is painful. How they will do it?
Yeah, that's wondering. I'm also wondering. But I do all my PCNLs under spinal anesthesia nowadays. I don't get GA. Even tomorrow I have a list around 3 or 4 PCNLs, all listed for a spinal anesthesia. It's fine, sir. No need
Yeah,
GA.
yeah.
I'm completely away from GA now. I do all supine PCNL, all under spinal anesthesia. It's time
Okay.
saving because if you give GA and do
Yeah.
PCNL, you can do 3 or 4 cases in my list. But if I do under spinal, I can go for a 1 or 2 cases more because our waiting time is very huge.
Generally you do PCNL under the supine or prone 90%. What will you do?
Honest with you, I started with a prone PCNLs in 2009, 10, 11, 12. But after some time, I changed to prone. Sorry, the supine. After changing to the supine, I feel it's life is very comfortable. Time, we save time. And puncture also easy. And I'm very comfortable. So after 10, last 10
I
years, I'm
also
doing.
feel I also feel my trainees, my fellows, my consultants are all doing supine. The puncture is more predictable, relearnable, and I mean, you can educate the proper, simple language that they do it. And puncture
Yeah.
usually cannot be done through other than calyx because it is lateral puncture. So I strongly feel learning supine PCNL is much easier than prone PCNL. Anesthetist is very comfortable, and surgeon, patient, all are comfortable with supine, is my opinion, especially if you are planning under spinal.
I agree with you, sir. Another thing, the time.
Yeah. And
So,
cost also
and you
3
can
to
give
5,000 Indian rupees will be extra for general anesthesia. General anesthesia is costly.
costly. Yeah, you agree.
Yeah.
I agree.
So
And
with
spinal
this,
anesthesia, you can give the direct feedback to the patient.
yeah,
Patient
yeah,
is observing what you are doing.
yeah, yeah. But
Only one disadvantage, you can't teach to the
yeah,
juniors. The patient is listening.
for me it is a disadvantage because I will be always talking. I will be always teaching whenever I am operating. So patient, that's why we do all under GA, and
Yeah,
it's okay. It's all for benefit of the patient. We have to think. There is no other option. Once again, I feel we finished 1 hour. Excellent session. Your method of
thank you, sir.
presentation is very crisp, and you focused on what you wanted to tell. It is a new subject. Many said it is impossible, should not be done. You should not see with a closed eyes. Always, there are some situations, yearly ones, that a simple hydronephrotic kidney, a little bit of infected, loin pain, patient is 20% ejection fraction. You just wanted to clear the stone and put PCN and remove next day discharge. Fairly okay. If you are experienced, take ultrasound, puncture, inject contrast, and then do dilatation. And after that, you remove the stone in 2-3 pieces, put nephrostomy. Next day, you remove, sometimes without stent if it is a single stone, without any other problem. Fairly acceptable. Giving local anesthesia is an art. What he is saying is, in the direction of your puncture, you give the local. Direction of the puncture is almost 10 to 15 degrees deviation, that's all. And he also mentions that 2 centimeters around the path you have given, the local anesthesia will act. That is, everybody knows. You need not give everywhere. So we are a straight track. PCNL is a straight track. And he also mentions that the capsule has to be given. Below the capsule, probably kidney is not painful except the pelvis distension. So pelvis distension will not happen in PCNL because water will be outflowing. So ureter is painful, so take care. Inside the kidney, parenchyma is not painful. Capsule is painful. The viscera is not painful that much. The rectus sheath and everything you can give in thin patients anesthesia. Quite logical in some patients. Very, very, very few patients. I thank once again Dr. Aravinthan for such a unique presentation. Will be a
Thank you,
good
sir.
addition to our pure urology. Thank you very much.
Thank you, sir. Thank you. Bye.
Okay.